Hi, we're continuing in the series of videos for parents who have children, adolescents, and young adults who have borderline personality disorder. This is really a continuation of the last video where what I suggested was that while it's extremely important that we benefit from healthcare professionals, therapists, pediatricians, and so on for the child, that ultimately the child lives with the parent, certainly as a young child, as an adolescent, and perhaps as a young adult or older. And it really behooves the parent to understand the BPD diagnosis, to understand the criteria, both those found in the DSM-5, as I noted, and those, as I have in my book, in the expanded criteria outside of the DSM-5, which still very much reflect borderline functioning. And that, in a sense, the parent has to become a healthcare professional to be able to identify issues and problems, and particularly triggers for the borderline adolescent, so that the child can live in a safe and healthy way with someone who understands what the issues are, both generally, the general criteria as noted for this category of issue, but just as importantly for that specific child in the family. We covered many issues regarding this in the last video, including the idea that BPD is a syndrome in the sense that it's a collection of issues rather than a disease as such, which has a specific empirical issue or a biomarker, and that it is a disorder in the sense that people with BPD suffer. It can be debilitating. There can be limitations or multiple challenges in that individual's life. What I'd like to do today is try to determine if we cannot identify a few models that I have noted in my book, and these are noted in other videos, but I thought it would be appropriate to have this as a second video to outline some ideas of understanding the disorder. The simple, honest-to-God truth is we don't know very much about mental health issues, especially as compared to medical problems. We don't understand the etiology, that is the roots of it. We don't understand how they will present with a particular person. The predictability of understanding a course of a problem is very difficult, whether the particular individual is now in an acute phase or in a chronic phase of suffering. There's very little we understand. And it's difficult sometimes to tell a parent, or for a parent to find out that a child has a problem, and the truth is we know very little. It's very interesting. Intellectual disabilities, which is just really one line in the DSM-5. Intellectual disabilities is probably rooted in 300 or perhaps 400 different chromosomal abnormalities that lead to the intellectual disability. Another very, very well-known example is major depressive disorder. Major depressive disorder is undoubtedly a larger rubric. It's a category, and within it there are multiple pathologies, issues, disorders, whatever you want to call it, that we can broadly understand within the rubric of major depressive disorder. But clearly there are people with major depressive disorder that have very few problems with appetite and very few problems with sleep. And there are other people with major depressive disorder that have insomnia and they cannot function. And they have erratic eating patterns that is really detrimental to their health. So it's one of the reasons, therefore, that you have these very different presentations is because ultimately these are labels we place, and we don't have biomarkers or exact understanding what these issues are. And the same goes true for borderline personality disorder. As I've mentioned in my book and in some of these videos, there is something, we usually think of borderlines as having erratic moods, unstable behaviors, and so on. They externalize a lot of their anxiety and abandonment issues. But there are borderlines that have been termed, and I have in my book, the quiet borderline, individuals who contend with these very painful issues internally. They don't externalize or show any sense of outer discomfort, and many people around them would never know that they're suffering with these internal issues and conflicts and so on. So let's look at a few of the models that I have. The first is the complex trauma model. While it's true that BPD can be rooted in a genetic predisposition, other borderlines may experience complex trauma as children. Complex trauma concerns severe and pervasive multiple harmful events, including abuse and neglect, that a child suffers often by immediate caregivers, and which causes developmental, cognitive, and behavioral dysfunction, prohibiting self-regulation and leaving the child feeling incompetent. The child may also feel worthless about himself, stupid, inadequate, terrified, guilt-ridden, insecure, and there may be self-blame and shame. This may shape the child's values, including proclivities and judgment, leaving him with an overactive nervous system, impairment in various skills, often a feeling of physical and emotional exhaustion, and an inability to modulate anger due to a chronic sense of betrayal and terrible distrust, even of immediate caregivers. Complex trauma overwhelms and remains with the person, serving as a new psychological foundation, undermining safety and trust so that the person feels unbearable sensations related to insecurity, forcing the person to continue to react as if the danger is still mobilized. And the person may react with flight or run. They may be unable to see anyone else's viewpoint or coordinate their own thinking or feeling, even causing devastating physical health issues. However, there are several caveats about how people experience trauma, and I've noted a few of them. First, the severity of a single incident can have systemically damaging harm and trauma. So, for example, most people over the course of a lifetime will be in an automobile accident. Often they're not that serious, a fender bender, but sometimes a little more serious. And we walk away, we exchange insurance and get the car fixed, and that's it. But some people, from a single harmful event, they become systemically traumatized. In other words, that single event, rather than repeated events, can be very damaging. And the same thing is with more serious events. You may be physically attacked, for example, by a burglar in your home or whatnot. And for some people, because it's a single event, they're able to understand it with some therapy, perhaps get over it and deal with their issues. But for other people, we're not quite sure. That single damaging event can have cascading trauma that very much harms the person in multiple ways in years to come. Second, microaggressions can add up to systemically damaging harm. So in other words, this is a great example. I saw someone many years ago. She was a black immigrant from the West Indies who was attending college, and she had not experienced racism where she had grown up outside of the U.S., and she said that she had experienced microaggressions for the first time in her life. Just little comments here and there, little verbal harms that poked at her self-esteem because of her race or ethnicity, maybe her accent, how she presented herself as a new immigrant to the United States. And these microaggressions over several years of attending college, although each one seemed rather insignificant, added up significantly for that individual. The third thing is people perceive harm in very different ways. And I've spoken about this before, about my grandparents. My grandparents were in a terrible automobile accident. This goes back about 70, 80 years. And my grandfather walked away. He never drove again. And my grandmother drove the next day and didn't stop driving until she was about 80 years old. And what happened was my grandfather grew up in Eastern Europe experiencing anti-Semitism and became very risk-averse, very conservative. My grandmother grew up in Connecticut, and although a poor family, she grew up with a sense of adventure and exploration, and she was quite liberal in a sense in her behavior. My grandfather, therefore, after the car accident, never wanted to take a chance again, and my grandmother kept driving. It showed two people in the exact same trauma, but their reactions were completely different given their histories. The second model after complex trauma is developmental disorder model. Again, complex trauma occurs when a person experiences multiple harms, physical, emotional, sexual abuse, often by caretakers and or neglect throughout crucial years of development. But the developmental model looks at development itself. In some ways, the low-functioning borderline is similar to someone with a developmental disability who must devote years to learning behavior, emotion, and thinking skills if he wishes to thrive. BPD is generally akin to a developmental disorder because many of the issues that the borderline contends with match childhood developmental problems, including separation anxiety, attachment issues, separation individuation, difficulty learning from mistakes, impaired social development, and various related behavioral and cognitive issues, and even oppositional defiance. This model suggests that the borderline has not adequately achieved milestones associated with appropriate childhood and adolescent development. Clearly, if the child or adolescent has not mastered age-appropriate development, then adulthood, almost by definition, will be very challenging. This is very much recognized with parents, where they see the child at an earlier age having difficulty, but as the child grows and develops, 13, 14, 15, 16, 17, as you keep going, often the parents think to themselves, well, isn't the child going to grow out of this phase? Won't the child stop being so needy? Won't the child stop with the separation anxiety? Won't the child stop with oppositional defiance? One of the core points of this model is to actually consider that it is the development itself which has gone wrong. There's actually a general area of study called developmental psychopathology, which argues that a lot of problems that we face, clinical problems, are rooted in development gone wrong. The third model I want to present is the autoimmune model. It's another way to conceptualize BPD, as the body and brain constantly strive for stability and security, even sometimes inadvertently causing self-injury to achieve this goal. In autoimmune diseases, the body's natural defenses attack what it perceives as a foreign invader or unfamiliar substance that should not be there. More accurately, the body cannot adequately differentiate between normal cells, which the body produces for healthy functioning, and foreign cells which have invaded because of infection or another reason. Autoimmune diseases have probably always existed, although it appears that the numbers have increased in recent decades. My personal belief that these have increased in recent decades because of processed foods, which are terribly toxic, especially to children. The problem is that the body does not react to unknown cells and substances, but often overreacts as the body's immune system is unable to properly identify the foreign invader or substance. When the invader is well known, such as common bacteria, the body knows exactly what to do and the matter can be resolved in a short time. But when the body is unfamiliar with the foreign invader, clear strategy is unavailable, leading to sometimes ineffectual or even counterproductive, overreactive defensive measures. Stress, particularly abnormal or overwhelming stress, can cause the body and brain to react or overreact, similar to an autoimmune physiological response. It does not matter if the stress is real or perceived as long as the person, subjectively, understands the stress as frightening, threatening, or sufficiently anxiety-provoking. Sometimes the best defense is doing absolutely nothing at all, allowing the body and mind to properly heal. But with BPD, the brain and body overreact and never really stop overreacting unless the brain is halted and checked. The last model I want to present, and again, I think this will be familiar for many parents, is the traumatic brain injury model. Traumatic brain injury, that's really brain dysfunction caused by outside sources, may result from various harms, including blows to the head, automobile accidents, sports injuries, and so on. There may be both immediate and delayed symptoms, some of which can be quite serious, resulting in physical, psychological, social, and neurological impairment or deficits in various kinds, immediately or sometimes throughout the person's life. Traumatic brain injury rehabilitation often requires a systemic approach to allow for proper healing, including psychiatric and psychological supports, occupational physical supports, neurological care, management, case management, recreation, vocational supports, and much more. Similarly, whether the origin of borderline personality disorder is genetic or environmental, it is helpful to conceptualize it as a brain injury, as borderlines benefit from a systemic evaluation of functional limitations and deficits, appreciating that only by tackling problems with an array of supports can substantial improvement occur, allowing for a better quality of life. The last thing I'd want to say in this video is that I know many adolescents scroll through the internet and try and understand their issues, and they come across BPD. I know many parents strive to understand their children and scroll through the internet and come across BPD. What I'd say is that don't assume that you're so fucked up. Don't assume the very worst. Many issues are misidentified diagnostically. There are all sorts of ways to get help that parents should be aware of, and that the adolescent or young adult should be aware of. And that even if this label does apply to you, it doesn't define you. And I would say to a parent, it does not define your child, and it does not define you as a caretaker for your child. And it's important to place in perspective these kinds of labels so as not to re-victimize yourself, in a sense, as an individual, or as a parent to re-victimize your child or yourself with this label, feeling that you're going down a helpless road, when in fact, although these are serious issues and the criteria I present in the book and the videos are obviously things that need to be regarded through professional health care, and they're time consuming, they're energy consuming, they're very difficult, help is available, and don't over pathologize. Don't label yourself to such an extent that it prohibits your functioning. Fight it. Get up in the morning, get the help you need, but don't define yourself by this. Similar to medical diagnoses, you can have a serious medical diagnosis. It doesn't mean that it defines your personality. It doesn't mean it defines your relationships. It doesn't mean it defines your hobby or interests. It may sometimes limit what you can do in life, but there are many ways to be functional and to enjoy life. And for the adolescent, and especially for the parent, don't take the label as a death sentence. Take it as a source of psychoeducation that allows you a better understanding. You're more informed about the issues. You're more informed about what triggers to look for. You have these models to conceptualize the problems. But at the end of the day, although this is a serious matter, it's not a definitive core identifying pathology that cannot be dealt with through professional, personal, family, and community help.